Okay, good afternoon again. Thank you for joining us. So, as usual, we come together and we have a bit of a chit chat on a specific topic. And I'm Bettina Moser, for those of you that don't know me yet, or it's one of your first sessions with us. And I entered into my career as a pelvic physio, and I spent 20 odd years in that interest, and in that I learned many different skills. I learned physiotherapy skills, and I had to learn some psychology skills, and I had to look at the body in a variety of ways. So I have subsequently done a life coaching certificate, and I do TRE, which is trauma release exercises, and I tend to focus my time now in more a kind of trauma informed perspective in a life coaching capacity. So that's me. I have with me, and I'm so excited. Thank you, Corina Avni, for joining us today. So Corina's one of our pelvic physios. She's just, honestly, Corina, you're one of our gurus, okay? She is just the most amazing scientific. She's like a walking encyclopedia. It's always baffled us that we can just like click our fingers and go, Corina, what research is out there and what's new and what's your opinion, and she will spit it out as if she'd prepared for it for days. So Corina, thank you for being here. You're on mute, so just unmute yourself. But just to carry on with Corina, so Corina has been teaching for many years. She teaches both locally and internationally. She has a pelvic practice in Cape Town. She'll give you more details on that. And she's did her master's in physiotherapy in 2017 and is now busy with her PhD in a topic that, Corina, I'd love you to give us more information on that. I'm going to hand that over to you. So, but thank you for your time. Thank you for being here. And yeah, thank you.
Thank you, Bettina, for the unnecessarily kind words, and thank you for the invitation. It's always nice to be able to chat to like-minded and interested individuals and people and groups on any chosen topic. And yes, I am doing my PhD, which I'm delighted by and with. And I'm looking at chronic overlapping pain conditions. What is so interesting as a pelvic therapist is that we see so many diverse different types of pain presentations, for example, irritable bowel syndrome or interstitial cystitis. And sometimes they have so much in common, and they behave so similarly, even though they are completely distinct diagnoses. And in fact, being a pelvic therapist, half of the chronic overlapping pain conditions, and we'll get into what those are in a moment, half of them are actually abdominopelvic presentations. So as pelvic therapists, we're exposed to these weird, used to be called medically unexplained symptoms, which gives you an idea that the medical fraternity doesn't know what is going on. Used to be, no longer. And they were medically unexplained because we couldn't account for the degree of severity or dysfunctional pain that patients were experiencing based on what was being found at the target tissue, the bowel, the bladder, endometriosis, migraines, fibromyalgia. So they were seeing more in common with things. So now we've got this concept of chronic overlapping pain conditions. And I'm just going to rattle off what they are quickly. I'm quite proud of myself. It's headache, both tension type and migraine. It's jaw issues, TMJ, TMD, temporomandibular joint disorder, and temporomandibular joint and temporomandibular disorder. It's fibromyalgia, irritable bowel syndrome, interstitial cystitis, something called vulvodynia, which is pain in the vulva. So it's a sexual presentation of pain and dysfunction, endometriosis, and of course, chronic low back pain. And these conditions together are seen to have more in common with one another across what we call phenotype, or the way something presents. So you could have two people with irritable bowel syndrome and two people with interstitial cystitis. And in fact, the one of the irritable bowel and one of the interstitial cystitis might be more alike than both of the irritable bowel in how they present. And it has to do with this phenotyping, which has a lot to do with the various biological factors, the various things that impact on pain. And that's also a long list. Are there any are there any specific ways, because I could talk about chronic pain forever, are there any specific ways or directions you would like me to take this? I mean, shall we start off with common patient presentations and then loop into what's going on behind that, and then maybe do some treatmenty stuff, if that's okay?
Rena, that's
So
fabulous, and maybe what you guys, if I would love it to be a little bit more interactive. So please, do me a favor, drop into the Q&As as Corina is chatting, so that I can pick that up and we can start to direct the conversation. It is a massive topic, and that's why we're kind of going, where should we go and where should we start and where does it end? It doesn't end and it doesn't start. So you can just direct us, pop your questions, and then we will go into that. But I think, Corina, that's great. Maybe just explain a little bit about, what's happening in a general kind of presentation and what people could, because I think, my experience in kind of anyone coming in with pain is that usually they have firstly more than one pain, which explains exactly what you're saying, and they feel frustrated. They've usually been to more than one person, often have more than one diagnosis, and not understanding that they're actually interrelated diagnoses. Given 100 different treatment types have been, and usually by the time that we see somebody, they have been with this problem often for years and years and years and feeling highly frustrated. So I'm going to hand over to you and your opinion on that.
okay, so I'm actually going to interrupt myself and us with almost a thought process. So many of these patients, irrespective of where the target tissue is, where the fire is going on in the body, they're aggravated by stress and anxiety. So often a marker of many of these conditions is an upregulation of a certain part of the nervous system, sets off a cascade of downstream reactions and presentations. So whether you're stressed and you get a migraine, whether you're stressed and your fibro flares, whether it's because you're so stressed, I left out chronic fatigue syndrome, whether it's because you're so stressed that your chronic fatigue syndrome has again kicked in, you've done too much and you're exhausted, whether you're, as you get stressed, your back pain flares up, your irritable bowel syndrome, whatever it might be. Stress works on our body in two main ways, and I say main because there are many more. We've got something called our HPA axis, or our hypothalamic pituitary adrenal axis, and this is involved with our response to stress and how the body primes us for a stress response. And often a long exposure where the HPA is activated, we land up with too much adrenaline, which changes to cortisol, and over time we deplete the cortisol, and that's our chronic adrenal fatigue. But that is one system involved. The other system is our autonomic nervous system, and I know, Bettina, you've already done a whole slot on that. So in its most simple form, our stress response in the autonomic nervous system would be a sympathetic nervous system reaction, and our happy person, the rest of the world calls it rest and digest, but I call it pee poo pleasure. That's our parasympathetic nervous system. We must include breathing with this. Depends which type of breathing. But often patients find themselves in a sympathetic nervous system upregulation. I've just heard a car backfiring. Was it a gunshot? Now, certain things have happened. Things have happened to my eyes, my salivary glands, my heart rate, my breathing, but it's also happened to my bowel activity, my bladder activity, what's going on in my blood vessels. So it's this whole body effect in response to stress. Now, if we look at what's been going on in South Africa this past week, I think there are a lot of people. I'm not in one of the affected areas, but I know some of my family are in an affected area, and the window slams and they're terrified, and this is because their stress response is being triggered. They're in a sympathetic upregulation. Now, with that go a few things. The sympathetic nervous system, because it's an evolutionary advantage, if a lion is running towards me, or I've just been bitten by a big dog, it's actually a good thing for me to feel pain and to have inflammation so that my injury can heal. But it's supposed to heal, get better, go away, and 6 weeks later, maybe I can't even remember which arm the problem was on. The sympathetic nervous system is what we call pro-nociceptive or pro-pain, and also pro-inflammatory. So if you're constantly under stress with your sympathetic nervous system firing, you're actually in an inflammatory space. And the more inflammatory you are, everything inflammatory kind of goes a bit haywire, whether it's your migraine or your fibromyalgia or your IBS. And we often find that we're not breathing or under breathing, we're breath holding or very shallow breathing, or and we'll say, I just noticed I'm not breathing. Whereas if we breathe with our diaphragm, deep, restful breathing, we're actually activating the vagus nerve, which is parasympathetic. And we find that we get stuck in the stress response, whether it's because of what's going on around us, like what's happening in South Africa this week, whether it's because it's what's going on inside our bodies. And I often say that endometriosis is like knowing the bomb is going to go off in a month's time. You're anticipating your period coming. You are anticipating the trauma of this upregulation, and there are so many other aspects to pain that immediately segues into something called catastrophizing. And the more concerned we are about the severity and impact of our symptoms, especially when no one can tell us what's wrong, and we're getting all these different diagnoses, and we've tried all these treatments and they haven't helped. We begin to catastrophize about our pain. What happens if I can't ever sit again because it feels like I've got a golf ball up my anus, or my coccyx is on fire, or my labia feel like they're swollen? That's the pelvic stuff. But what happens if I can't spend a day at work because I get my low back pain or whatever? So there's these pathways involved in the perception of pain and what makes it chronic. And one of the other underpinning or primary considerations is this concept of something called central sensitization, which brings together the way the brain responds to what should be a transient input of trauma, and how over time, with chronification, when something becomes chronic, the brain has actually primed you for an onslaught of trauma. And there is this upregulation of these inflammatory markers. There's a change in the sympathetic nervous system, a sympathetic activation. Your heart rate becomes less variable. It is more, it is more consistent, and that's a feature of sympathetic nervous system activity. And essentially, these patients are stuck in a fight, flight, freeze, fawn, fix response of the nervous system, and they are not activating this downtime, the poo pleasure. It impacts sleep, it impacts mood, and therefore anxiety and depression. There's a lovely collaboration called the MAP Research Network, which is the multidisciplinary approach to pelvic pain. And they identify a whole range of other comorbid symptoms, comorbid things happening together at the same time. And it includes things like tinnitus or dizziness and nausea and reflux. These are all under the control of the autonomic nervous system. Palpitations, breathing issues, pain, tingling, particularly bilateral tingling. It's almost like you can throw energy between your fingers. It's something called carpopedal, and it's because of a change in your breathing and the blood gases change. So there are so many of these features, and maybe you go into the doctor or the physio and you say, look, I've got pain here, or I've got pain when I sit, or I've got pain when I poo. And we all get completely, what's going on with the bowel, and whether it's a colonoscopy or an internal exam, or we've used ultrasound, and whether we're doing Kegels or not. Everything is focused on what's going on in the bowel. And actually, when we find out that you get your pain every time you're terribly stressed. If we can manage and when you're terribly stressed, you also have nausea and headaches, and you clench your jaw, and your sleep is bad. And instead of treating the bowel and forgetting about the headaches and the jaw and the sleep, if we were to address your nervous system and get you out of a sympathetic nervous system upregulation and activate the parasympathetic nervous system, all of those symptoms, bowel, headaches, tingling, clenching, all of those symptoms can be impacted. I call it this putting out little fires everywhere. And the analogy I use is that you're a house, and maybe your pelvis is the lounge and your lungs are the dining room. Who cares? The thing is, there are all these little fires everywhere, and you keep running around this pill for that headache and these exercises for that stiffness, and we keep putting out little fires everywhere. But if the common problem is the electrics supplying the house, and it's faulty electrics that keep starting little fires everywhere, it would be better to correct the electrics. Um, and on top of that, if these electrics misfire and there's a little fire somewhere, it's not just the smoke alarm and the water thingy that gets triggered. The whole fire brigade rocks up with their hoses. So there's this massive overreaction of the nervous system in response to little activation episodes, whatever they may be. I feel like I'm talking to myself. Isn't there a question or something?
No, please, we're listening. Carry on.
Uh, yes.
So, Corina, like I think if we had to, like, because of the nature of kind of all these little fires popping up, I think it becomes a very confusing, and I think because the fires can sometimes be in different rooms of the house, it's like they're different almost chiefs in charge in each room. And then it's going from the neurologist to the, a colorectal surgeon, to the gastroenterologist, to the pulmonologist, and it becomes a very kind of confusing space to be in when you're trying to manage your own health and well-being, and I think the difficulty is in people understanding their own conditions, and also medical people understanding, of giving the big picture. But if you had to look at somebody coming to see you, let's kind of stick just with the pelvis for the lack of, just seeing that we are pelvic physios, and I think some of those in the audience will be having pain in that area, and looking at trying to understand that better, and looking at kind of I have this problem here, and I don't know who to listen to, I don't know what to do. What type of, how much do how would you start to look at assessing the local versus the systemic? Well, how do you know where the fire is and what is central and what's not? And
So first of all, there is almost a profile, and when I say almost a profile, it is more the patterns and signatures. So it's not that every single person with pelvic pain has anxiety or is depressed. Many are, and many are aggravated by stress, but there will be other individuals who perceive themselves not to be stressed. They will still usually find that their symptoms flared during times of challenge, even though they might perceive that they deal with it well. Not everyone is stressed. Many are. And there are these patterns or signatures whereby there might be a primary thing that bothers them the most, whether it's the bowel or the bladder or pain with sex. But there are then often multiple other, and they might be seen as almost minor. Um, minor when I get very stressed, I sweat a lot. I don't see this as a medical problem, but that immediately is my nervous system. And in fact, if you sweat too much, they do something called a sympathectomy. They cut your sympathetic nerve supply. And if you sweat too much in your palms and they cut your sympathetics under here, then you just start sweating on the soles of your feet. But if you get someone to calm down their sympathetics, you calm down their over sweating. So many have anxiety. There is this pattern or the signature of comorbidity, things going wrong at the same time. There are often markers, not in the truest biological sense of the term, inflammatory markers, which would be physiological measures of inflammation. But there are many things that trigger there's chronic inflammation going on here, whether it's things like, it's all the things I've mentioned, along with things asthma and reflux, and some other chronic conditions. So there's often inflammation. There is often a sleep mood aspect. that again, it's not that they necessarily have to have poor sleep, but certainly when their pain is bad, their sleep is less good. Even if they're sleeping for longer, they find they're unrested. And I think what I'm seeing more and more, and again, this is not true for everyone, and it doesn't exclude you, the individual, from having pain simply because you don't match the profile. But what we are seeing is there is something related to being exposed to what we call adverse childhood experiences or trauma in childhood. And trauma in childhood, these kids present, so whether you're a refugee or you've been hospitalized for more than a week, or you were born prematurely, or you were badly bullied, or there was abuse in the home, um, if you've been exposed to this kind of trauma in childhood, your nervous system gets set, and the new base level is the sympathetic response. So you are living in a pro-pain and pro-inflammatory setting within your body, and we see these kids present with multiple, again, unexplained medical symptoms. And most of them have many multiple unexplained medical symptoms. Um, and so instead of this being, it's all in these kids' heads, there's an argument for a new physiological baseline of function where people are, because they have been exposed to trauma, their body is almost stuck in this trauma loop, which because of its pro-inflammatory and pro-pain aspects, renders us experiencing inflammatory and pain conditions. The ACEs, adverse childhood experiences, are different to PTSD. PTSD is almost more severe, and it's got different subsets. But adverse childhood experiences really do change the way your body works. My heart breaks for these kids, refugee kids, because they are being set up by their environment for a life of ill health, not because of the lack of exposure to proper nutrition or health and safety and medicine, simply because their nervous systems are predisposing them to disorders and conditions of chronic pain and inflammation.
I think going on and I'd love to have a kind of trauma discussion at some point in the future, but just going on that childhood, the adverse childhood environments, the research is also showing that, and this is a thing, is that very often when we ask, a lot of people will have a very specific trauma that they recognize as a trauma, but there's also this developmental kind of trauma of just being in an environment that's stressful. Mom and dad have to work, there's financial stress, or there's an alcoholic parent, where it's not kind of I was bullied and beaten, but I lived for 10 years in a very stressful environment where I constantly had to be the good girl, or I had to conduct myself in a certain way. I couldn't relax easily because I knew if dad came home and he'd been drinking, maybe they'd be shouting, or parents fighting, or this makes it so interesting, because very often and has always been an interest for me, as you know, Corina, I always dabbled into kind of all the emotional stuff when I was not allowed to, per se, because it really fascinated me that every single time I had a situation and when I say every single time, if I looked deep enough, I found it. When it came to chronic pain conditions, or stubborn conditions that don't want to resolve just with a bit of local, and this is the difference, is that, do you have a bladder that is giving you trouble, or is overactive and makes you want to wee all the time, or a constipation, and if you just change your diet or do a few exercises, or it resolves itself? That is very different to these types of conditions where it's not a simple local treatment, that if we treat the local area, it resolves itself. And I've often said that we have to almost get a whole basket of eggs together in a treatment form, and and often do it all together at the same time. So people have been to on a to a dietitian, but they've done it separately over 10 years. And it's like, but we've got to put it all together. So it's a fascinating discussion around, how do we begin to even start managing these types of, and maybe you could speak to that a little bit, what your thoughts are and how much is local and how much, yeah.
Okay, so I first want to address your thing about the alcoholic parent. We've always thought that the sympathetic was fight, flight. They added in freeze, which was the PTSD. And in fact, that alcoholic
Karina, I'm
parent.
going to interrupt you. So
Yes.
PTSD, do you want to just, for those that don't know what that abbreviation is?
Post-traumatic stress disorder. Post-traumatic stress disorder, and the alcoholic parent fits in with this concept of fix or fawning over someone, looking after. Because if I hear the door slamming, I'm not going to go and punch dad in the face or run away. Or freeze. Well, I might freeze temporarily, but I'm then going to go get my two younger siblings, put them in a back room, and then race off and get dad's slippers and another beer and put them down just next to him quite quietly. So the response of my nervous system in response to a stress in which I'm powerless is often this fix or fawn, which I think more of us are privy to or subject to than we care to admit. So that was the one thing. And then it's so what the way, and then I was gonna because that was just what I want to say, and then you wanted to know, and I had it in the top of my head, and now it's gone.
So we spoke
Yibbity.
about how much do we treat locally,
Yes.
and
Oh, yes. Yes. Okay. So that's exactly what it was. So what we actually find with something called interstitial cystitis, there's a diagnostic criteria that all the patients want to see so they know they've got interstitial cystitis, something called Hunner's lesions. These are inside the bladder, and you see them on something called cystoscopy where they look into the bladder. Interestingly, patients with Hunner's lesions often have less pain and dysfunction. And it's almost, I mentioned earlier, this phenotype. So 20% of patients or less, 10% of patients have Hunner's lesions, and they have less irritable and irritative disease process. 90% do not have Hunner's lesions, and they have more of this sort of systemic generalized upregulation. So some people do have more target tissue pathology. There is something wrong at the bladder level, but it's far fewer, and their symptoms are less severe than the majority of patients, and I'm speaking specifically with respect to interstitial cystitis here, with the majority of patients who in fact do not have these lesions, and the dysfunction is not actually at the level of the bladder. It's just that the alarm is being rung at the bladder or in the dining room, whatever analogy we used earlier. And that's where your nervous system goes ding, 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 danger, danger. And whether it's having a poo or having a wee, or and again, as you said so beautifully, if it is something as simple as how to poo and eating the right food and not having too much caffeine or alcohol or preservatives or whatever the thing is, or too much of whatever doesn't work for you, many individuals can calm things down quite nicely. But if it's less what's going on in the bowel with the microbiome, and it's more in the nervous system that supplies the bowel, simply eating the right diet isn't sufficient unto itself. And perhaps it's a combination of the mindfulness techniques, deep breathing, a conscious effort to manage inflammatory markers. I understand you did another very good webinar last week on chronic inflammation and diet, nutrition for inflammation. And sometimes one has to do a variety of, not sometimes, often, one has to do a variety of modalities at the same time in order to provide support for the various aspects that are contributing not only to the generation, the creation, but the maintenance and propagation of this particular dysfunction. And really we like to think of it as an imbalance. And if something's out of balance, if we can just tilt it a bit, do a bit more of the thing that we need a bit more of, we can get things back in balance. Things are not broken. And yes, there are some individuals who are crippled by pain everywhere all the time, but the majority will find that even if their base level is 4 out of 10 pain, there are times it's a lot worse, but it will come back down. Yes, they go through periods where it's 7, 8, 9, 10 out of 10. But it's trying to find that particular collection of factors, whether it's the amount of sleep or the amount of water they've drunk or something relaxing, be it exercise. I've found some of my patients respond well to the term exercise, but a lot of the time I use movement and activity, and I stay away from exercise because so many of them feel exercise imposes it's something that needs to be ticked off rather than simply enjoying being able to move in their bodies freely. So we often stay away from the concept of exercise, especially with our fibromyalgia patients, and our chronic fatigue. And we're seeing our long COVID are also struggling because they cannot achieve anything the way they used to. So we see these individuals who have severe symptoms in a variety of systems, and with a combination of responses, treatments, interventions, we can often create a greater resilience, more battery, which gives them more of a buffer. So they might be on quite a strict restriction diet for 3 months, 6 months. But once that restriction diet, and that's actually not true, because a restriction diet is much shorter, and after a period of time things are introduced, and it shouldn't be for 3 or 6 months because that's what renders it unhelpful. I've just got a number of persistent patients in whom they really have had to have longer periods without introduction because they are so sensitive, and so many things flare and aggravate them. Interestingly, whilst irritable bowel syndrome responds very well to something called FODMAPs, fructo-oligodipolysaccharides, it's a type of short chain sugar. Interstitial cystitis, although there's a whole range of foods that might be irritative, usually an individual only has between 5 and 7 foods that actually are triggers for them. So interstitial cystitis, I see painful bladder syndrome, bad bladder pain syndrome, is often well managed with the correct intervention. But in a patient who doesn't have Hanna's lesions, and it's all related to the nervous system, if you're not addressing what's going on in the nervous system, you're always just trying to put out the little fire at the bladder. And these symptomatic treatments, let's relieve your pain in your bladder or give you medication for frequency, urgency to mask the symptom. We haven't actually corrected the driver of dysfunction or the faulty electrics that keep setting the fire in the first place.
Thank you. Corina, I'm going to go to a comment and a question. So there is a comment around a patient that I saw, and I'm keeping it confidential purely because this does go on to YouTube. So for those of you that would like to share it or whatever, yes, you can absolutely pass it forward. That's why we're doing this. But the comment around I was working around the jaw area related to the pelvic floor, and she's saying as my jaw heals, so my pelvic floor is getting better. So I just want to say thank you. Please tell us how to activate our vagus nerve and parasympathetic nervous system. My problem is activated by my jaw, as I've had recent surgery, and I find that if I retract my jaw, it kind of helps calm me down, and it seems to affect my bladder and make me less desperate to go to the loo. Does this make sense?
I'm just retracting my jaw one moment. Excuse me if I look a bit weird. Um, so first of all, our sympathetic nervous system supply comes off our sympathetic trunk, which is in our thoracic spine, and our parasympathetic supply actually comes off from here and here. So you can see how if we are splinting or bracing or locking, we can really lock down both at the top of the spine and down at the bottom of the spine. So the neck giving often contributing to jaw issues, and of course down in the pelvis. Vagus nerve, the vagus nerve is fascinating. It's got two branches, an ascending or a branch going up to the lungs, to the diaphragm, and a branch going down, which is, it doesn't transmit as fast. It's an unmyelinated branch, and that supplies the bowel. And what we see, if we've got that, if we've got stress breathing, so or just simply not breathing at all, that's sympathetic nervous system. But the vagus supplies the diaphragm. So simply doing diaphragmatic breathing is making your vagus fire. The more you can look after your gut health, whether that's with correct diet and defecatory dynamics, how we poo, or it's addressing our gut microbiome, and the world is coming for the gut microbiome. Um, Gut health further contributes in to our vagus nerve activity. So we see some of our patients who've had hemicolectomies, they've had some of their colon removed for cancer or whatever. They'll often find a degree of anxiety afterwards, which we think is driven almost by the input of the gut back into the nervous system. So vagus nerve, deep breathing. There are some stretches we can do to try and activate things. There is some people do vagus nerve stimulation, which is not something I do. Or am overly familiar with. I've looked at a little bit of research on it, but really a lot of it is mindfulness, breathing, and mindfulness interoception and awareness of what's going on in our bodies, which is what many of our chronic pain patients lack. Is they don't actually listen to the messages coming from their bodies. They 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 might say, oh, but I'm getting all these messages all the time. They're getting pain messages, but they actually haven't listened to the fact that their colon is full or that their bladder was full. Um, and so we start to prioritize inappropriate messages of pain and what's going wrong, rather than normal the normal flow of switching on and switching off, something called homeostasis. This is ability to maintain balance, and we lose that, whether it's because of the nervous system, whether it's tight muscles that are impacting on in function in the area, whether it's persistent postures we're holding. Am I sitting at my computer with a poking chin or with my tailbone tucked underneath? And this is my posture throughout the day. So there are many things that can go wrong, but it's not simply as so often we tend to do, the physios, let's do the joints and the muscles and the nerves and the posture, and some breathing exercises. And increasingly, we have to acknowledge the psychological aspects, the sleep, mood, anxiety, depression. We've got to look at past trauma, and increasingly we can't treat this population successfully without being aware of the immune and chronic inflammatory changes, because that's what predisposes us to have more and more severe of these chronic overlapping pain conditions. So we might have one for a year or two or five, but in time that one will be persistently there, and we're now going to pick up another. And we know this with fibro. Most of our fibro patients also have very irritated bladders. Some of them get the diagnosis of IC to go with fibro, but not all of them do, because only 10% of them have got Hunner's lesions, which is what they're looking for on cystoscopy in order to be able to diagnose IC.
So the thing with it is that it can feel, and this is one of my experiences in it involves a lot of kind of understanding and education. You've got to really start to be able to understand your body, and understand. And a lot of people get very overwhelmed when we start to speak about all these kind of interrelated systems that are, and it's here and it's there, and it's, yes, I have that as well, and I have that as well. And if that's not enough to increase your anxiety, I don't know what is. Okay. So, and it becomes this vicious cycle. And I think that the main thing that I try and relay to anyone that is struggling with any form of kind of pain or dysfunction in the body that is kind of more chronic is that if you are finding all these different things, the great thing about it is if we can find a kind of basket of eggs of solutions that actually resolve all of them. So you're not actually dealing with a headache on one side, with a jaw problem on the other side, with a pelvic floor or a bladder dysfunction or a sexual pain or you don't have 10 problems. You've got one imbalance. Okay.
Exactly. And it's when doctors say there's nothing wrong with you, doctors should be saying there's nothing sinister that my tests can detect. There's no cancer, there's no bleeding ulcer, there's no broken bone sticking through the skin, there's no terrible infection. And as patients, we should be reassured, okay, it's not cancer, it's not a horrible infection. But then what doctor doesn't follow it up with is, so it's everything's okay, there's nothing sinister wrong, but clearly there is an imbalance. And for whatever reason, your various systems are telling you that there is danger, trauma, pain coming from an area. But really, we do get into therapy then, and whether it's psychotherapy or physiotherapy or any of the therapies, um, we're looking at changing the body's normal, where in this case normal is the pain and dysfunction setting. So we obviously talk about version 2 of you. Version 1 was you before all this happened. Version 2 is you where you are now, and version 3, you're still you, but we're going to change that response to stress. And we can't stop your boss coming in screaming at you, but maybe you sit there quietly, count backwards from 10, and attach a swear word from a foreign language to each number you come across. We can't always get rid of our stress, but we do try to manage it. And many individuals will notice that when they manage their stress, their symptoms, all of their symptoms are better. And maybe not all, maybe 8 out of the 10, and maybe 2 of them are still persistent. And maybe for those, we do need to work on posture, change the diet, get out and move more during lunch hour. We can't fix terrible posture with some deep breathing and telling yourself your boss will not be your boss forever. um, Sometimes you do need to get up and move. And as much as I blame the doctors for letting the patients down by not providing them with sufficient information, I also blame us, the patients, because we want answers and we want them now and we want them to be simple. So when we do have to go through a process of change, it's difficult. And instead of doing the difficult thing where we acknowledge that actually we do pee too often and we don't drink anything like the right amount of water, and actually we have far too much coffee, but we like coffee, so we don't want to give that up. And we are very stressed, and we know that walking helps us, but walking, who wants to walk? Or whatever the thing is. And we don't want to take responsibility for actually what needs to be done in order to live healthy, balanced lives. And we take on too much, and we don't get enough exercise or movement, and we don't ingest the right types of fluid, right amount or type of fluid and or fiber. Um, just read a fascinating article comparing fiber and the fermented foods and what they did to the gut microbiome, and a marked change in eating fermented foods, which then had all these impacts on other aspects, from sleep to anxiety and depression. So eating fermented foods, they were looking at how it changed the microbiome, but that also then had a knock-on effect. So the bugs in your gut are impacting upon how you think and feel about things. And the more we eat bad foods and processed foods, the more we disturb that balance, and then we can land up with bugs there, but the wrong kinds of bugs. And these can lead to give us everything from feeling foggy headed to bloating and gas and cramping, all depending upon the type of bugs, whether they're bacteria or yeasts or fungi. Um, so so often we, the patients, don't want to do what needs to be done, like doing some meditation. Patients go, I'm always so much better when I'm away in the mountains. And then they come back to a god awful job that they hate and complain about their terrible pain. But whenever they're not at work, they actually feel fine. And could they take a sabbatical? And if so, if all their pain is gone, and then after 6 months they go back to their old job and their pain comes back, maybe it's their job that's giving them all of these symptoms. It's not to say that it's all in their head. It is the way the nervous system responds to a particular set of circumstances and creates a a physiological feedback in response. And my boss walks in the door and I've tightened my pelvic floor. It feels like I've got a Lego block up my ass. I kind of stopped breathing. I'm now going to be a bit constipated, which might make my hemorrhoids pop out. Oh, and that's made me quite uncomfortable. So I'm probably at my desk like this, which means I've now got poor posture here. So in a couple of days, I'm going to get a headache as well. And kind of everything's gone wrong. But it was a stress response that initiated a cascade of dysfunction that then culminates in pain and everything going wrong all at the same time.
And I think, thank you for that. And I think what when we start to look at these types of conditions and where to start, it's very difficult for us as medical professionals or as the doctors in the short time that we spend with someone to really get a full picture. So I think a lot of people over the years came to me and said, but like you said, the doctor can't find anything, and I'm like, well, that's great. Like much rather have him not find anything or her but not find anything. But it leaves it leaves you feeling helpless, or it's like, we'll go to the psychologist and let's start some, and it's like, the problem's not in my head but it's in my body. And I think we've just separated ourselves out. The head stuff's here and the body stuff's here and this is there, and it's all compartmentalized in a separate room, almost, as going back to that analogy. And I think when if we had to guide people through their I always say to my patients that it's an introspective process. It's about you starting to introspect on what is happening in your own body and bringing that to the table and having a look at. And yes, we want to rule out sinister things, so it is important to go and have this the pain checked out, to have the necessary test to see that there isn't anything major happening there. And then from there we start with generally looking at the local areas, and then we start to expand out and looking at all everything that's coming from that, and finding a meaningful way of incorporating a variety of strategies. They don't have to necessarily be very difficult, they don't necessarily have to be very time consuming, but what I find is so important is that the mindset of how do we look at this problem needs to change. I don't know if you want to comment on that.
So if you wouldn't mind, I realize I didn't respond earlier to the local versus global things. This isn't a full presentation, but I've got I'm going to share a couple of slides. It's not a lot. It's not a lot, but slideshow from current. No, we don't want that. So this is just a lovely little paper from 2020, and it looks at these chronic overlapping pain conditions. We are going to get to the thing you said in a moment, and it's on this. But we can see all the ones in pink down here. These are all the pelvic, abdominopelvic related pain conditions, and these are the non-abdominopelvic related pain conditions. This was a lovely report released in 2015 that looked at the impact of chronic pain, these chronic overlapping pain conditions. But this is what I wanted to show you. So over here, why will this not go away? Oh no, go back. I want this to close down here. Okay, so this is our past thinking, and this is our future thinking, and it goes from our scientific understanding. Each condition is distinct with its own disease mechanisms at the target tissue, and our future thinking is altered neural, immune, and endocrine activity common across all disorders. So for example, your medical management, for an example, all pain due to peripheral damage or inflammation in specific target tissue and will respond to treatments indicated for acute pain, for example, opioids and surgery. But in our future thinking, some pain due to dysregulation of neural, immune, and endocrine systems and will not respond to treatments for acute pain. So medical care is fragmented into specialties by body part, and here patient-centered care with a multidisciplinary team approach. So here, palliative treatment aimed at alleviating symptoms, treatment guided by individual pathophysiology. So we're looking at trying to change the underlying mechanisms rather than go and put out each individual little fire. I'm moving you around here. So for example, with research, if disorders have been researched separately, but really we're now trying to look at these more common or underlying mechanisms, the subtypes and phenotypes that we see. So I just wanted to show you this is our past thinking and our future thinking. And then this was just another little thing. We don't necessarily need to look at our whole legend down the side, but this is to show you how complicated things are. So we've got our environmental contributors, which could be anything from physical trauma, abuse, infection, smoking, and psychological life stresses. But then we've got all of these things that feed into it: our pro-inflammatory state, our impaired pain regulation. We can't switch pain off. This, of course, changes our autonomic function that we've been talking about, our neuroendocrine. These are our various hormones that impact on the nervous system, for example, adrenaline and cortisol. And this is all about we've got mood, anxiety, depression, stress response. Somatization is feeling pain in your body. These are the various receptors that are involved. So this is to come back to what you're saying about how complex everything is and how it really isn't about one aspect. And we can't be rushing off treating everyone through one receptor or one mechanism, or assuming everyone does have trauma in their history. But if someone does have trauma, we need to consider that it set a new physiological baseline for neurological function. And if someone has bowel problems, we need to consider that the microbiome is they're in a state of what we call dysbiosis. They haven't got the right bugs in the right ratios. And you can give someone as much pain medication, exercise, and postural correction as you want, but if they have a candida in the bowel, they've got the wrong E. coli, they've got yeasts and candida and other bacteria, these things also set up the pro-inflammatory state. So for some patients, they might need the microbiome addressed. In other patients, they're going to need the support with dealing with the trauma and being able to reactivate the nervous system in a way that allows for this homeostatic balance and flow between the sympathetic action, the human doing, and then the parasympathetic human being space between. And I believe life is not about the sympathetic out there doing. I think it is those moments between the parasympathetic. Someone asked earlier how to activate the vagus nerve. Well, I have my cat sit on my tummy and it's very difficult not to do deep breathing whilst you have a cat on your tummy. So sometimes it's enforced stillness. If I'm lucky, it's for up to half an hour with a cat rising and falling gently. And it's difficult to answer emails and feel stressed when you have a cat sitting on you. So I think that you could use a heated beanbag or a happy huggy, but I suggest a cat personally.
In our previous video, Corina, we had a discussion about the practical tools of regulating the nervous system. So there is another video that you can go to that I took you through some basic mindfulness processes and a couple of kind of ideas around that. So there is something that you can refer to with regards to that. I have a question here, Corina, and maybe you can help with this. So there is a lady that's, the initial question was that she was interested in understanding the progression towards kind of the more chronic pelvic pain picture and how that can progress. I've just asked her to expand on that. So in expansion to that, she's saying that what she's wanting to know is about the progression of localized pain to something more like a syndrome or an all-encompassing situation like what we're talking about. So she's saying she's experienced chronic vulvodynia for ages and has endometriosis. And then more recently, she's battling with hip pain. How common and likely is it for pain to extend to other parts of the... So this is exactly what we are chatting about, So maybe you just want to...
So often there's something switches things on, whether it's a bladder infection, an episode of thrush, a particularly rough sexual experience, piles, an episode of constipation, something will switch on the system. If it's an infection, we need to get rid of it, be it candida or a bladder infection. But this will often set up a little local dysfunction. So maybe I've had a tooth infection, and because it's been sore, I've been clenching my jaw a little. And even though my tooth is then sorted out, I've still got a tendency to clench my jaw. This has become my functional response. So with the vulvodynia, I'm not surprised if you've kind of been tightening up down below a bit. And then it's interesting because you mentioned vulvodynia first and then endometriosis, but I would kind of assume that the endometriosis actually came first. And it's because of stuff that's been going on from the endo that you've possibly been going into a little bit of a fetal position. Oh, it hurts. And because of that, there's been a tightening in the pelvic floor, which has presented as vulvodynia. And the more that restriction, tightening, bracing, oh, it feels so sore, the more that has persisted, the more it is setting up what we could probably consider to be musculoskeletal dysfunction in the pelvis if it's extending into the hip, but it might just be a referral pattern. It might not actually be musculoskeletal dysfunction. It might not be impacting on things like movement and activity. So for some individuals, that tightness in the pelvic floor, they might find that when they're walking upstairs, they get a stabbing pain in their groin or something. For other individuals, it will simply be a pain referral. What we often find in the pelvis, although sometimes the pain is where we find dysfunction where your pain is, so often it's not. So you might be feeling pain in the coccyx or the vulva. And in fact, when we do an internal, the pain itself is not, I'm just going to use a model quickly. The pain is not superficial, and you might be feeling the pain on the outside over here, for example. But in fact, if we do an internal, we might find that there's tight muscles in here, and these are contributing to your experience of pain. Likewise, pain in the coccyx is so seldom actually the coccyx. And if you press on the coccyx and you spring on it and you press, people say that's not my pain, but you move off to the side and you press on the muscles at the side and they say that is my pain. So what you've just said, you said vulvodynia and endometriosis, I believe, suspect, would 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 expect that the endometriosis is the primary condition that's been there for longer. The vulvodynia is, I'm not saying it hasn't been there for a long time, and maybe in fact your vulvodynia was diagnosed before your endometriosis. Maybe you were presenting with vulvar pain, and on on examination to try and find out what was causing the vulval pain, perhaps they came up and found some endometriosis. But if that is the case, it is possible, probable that the pre-existing endometriosis resulted in a degree of imbalance, whatever that might mean, which was and possibly a component of muscular tension, which is then presenting as other dysfunctions. However, having said that, endometriosis is one of these inflammatory conditions, as is vulvodynia, both chronic overlapping pain conditions. And it might be less of the musculoskeletal physical response, and it might be more of this, it's another inflammatory condition that's been switched on.
And that would be
And then,
related to your nervous system. Yeah, so that's where we
so
would look more. Yeah.
But again, there's the neuroendocrine aspects, there's the immune aspects, there's the autonomic nervous system aspects, there's the central sensitization and peripheral sensitization. Sometimes we've got too many nerve fibers in the area. And if you imagine taking your finger and touching your eyeball, it's not comfortable, but it's fine. Take that same finger and touch an eyeball that's irritated, and with that same finger, oh no, that's really quite scratchy and burny. So the same stimulus can actually provoke a very different feeling when those nerve endings are switched on, irritated, when there's more inflammation in the area. So stimulus or touch in a hyper irritable area is going to provoke a greater or an amplified response. These patients often then have less ability to dampen or calm it down, going, I felt a bit of a twinge, but that's okay. And this then further has the brain listening for pain, which then sets up more inflammation and everything kind of gets worse. It's not worse because it's bad or severe or there's something terribly wrong with you. It's that many things are going wrong at the same time, resulting in this experience of pain. But quite often, if we've done a good assessment and we've identified what your drivers are, be they diet, be they movement or lack thereof, be it a lot of inflammatory markers, be there trauma in your background, if we've done a good compassionate history where we've allowed you to share your story and we've asked probing questions about things that we feel might be relevant, we should be able to say, look, this sounds like it's 50% your microbiome, 25% stress and anxiety, and 25% diet. Or this is 100% diet, and you cannot keep living on McDonald's or whatever the thing is. So different for different people, it's going to be different things. And for someone in whom the predominant driver is something that they're invested in, whether it's diet or their work, it's very difficult to change those behaviors and patterns. I've had pilots with pelvic pain, and you cannot tell a pilot not to sit for hours.
And I think this is
Can't
the
tell.
difficulty. Yeah, is that some of the things we're not in control of, or there's a relative amount of adjustment that can be done in a certain area, at least in the short term, if you are wanting to change a career because your career is not working, that's that's something that unless you're fortunate enough to be able to resign tomorrow, for most people that's a progress, something that takes time. But I think the other in the on the back end of that question, I think that she's also interested in understanding like the progression of this. I think she's possibly concerned like where's this going to go. Maybe you could comment on that, Corina.
Where's it going to go? I would like to say that with the right buy-in from you and a good therapist, and the correct basket of eggs, correct basket of modalities, whether it's nervous system quietening, whether it's dietary changes, whether it's increasing your fluid, whatever the things might be, whether it's stress management, cognitive behavioral therapy, breathing techniques, thoracic mobilizations, whatever might be required. If you can find the right balance, letting go your pelvic floor muscle contract and relax, with the right collection of often quite simple lifestyle modifications, you can often create a sufficient shift in your experience so that things are not as bad. It doesn't mean that everything's magically gotten better. But for example, if you're hardly doing any exercise and eating the wrong food, we get you doing some exercise and improve your diet, and things are not as bad. It doesn't mean they've gone, but now that things are not as bad, we can actually get you doing a bit more activity. And we can add in something else because you have more resilience. And that then gets you two steps further towards a balanced or pain-free, functional space. We try to avoid this concept of pain-free because if your pain is 10 out of 10 and you're doing nothing, we're not going to wait for your pain to get to 0 out of 10 before we start get you doing stuff. If we can get it down to 6 out of 10 and get you doing a little bit, and then get it down to 4 out of 10 and get you doing a little bit more, and then get you down to 3 out of 10, and now you're actually quite active. And in fact, because you're quite active, that has other positive impacts, and that is what's going to get this down to 2s and 1s and nothing out of 10 if we're grading pain on a visual analog scale with numbers, because often that doesn't give enough context. And patients are often saying, but it's not even pain, it's discomfort, or it's an itch. A 10 out of 10 itch can drive people crazy. It doesn't have to be pain. A feeling of swelling can be unbearable. So what we don't want to do is ever undermine your experience. Your experience is your experience, and what you say is true. And it's a case of it's detective work. It's trying to problem solve so that we can get as much balance through as many systems as possible. But if you've also got a pre-existing thyroid condition going down, if there is something like endometriosis, we can't always fix or cure everything. It's not about fixing or curing everything. It's about doing the right things that encourage you towards being this version 3 of yourself, the one with the less pain, rather than allowing too much exposure to those things that we know are keeping you in version 2 of yourself, this one that is maybe not crippled, but certainly affected by pain and dysfunction, wherever it might be.
And I think really the scary part of being in a chronic and with there's a pain cycle, and then there's a chronic pain cycle, a pain cycle of I have pain, I had my toothache, and now my toothache's better. Okay, that's a very different physical psychological experience to a chronic pain pattern. And the thing with it is that I think in understanding the nature of how pain overlaps, there's different types of nervous system and how everything fits together. I think what happens is, and it's part of why I've wanted to do kind of these webinars, is from a space of understanding, because it's scary to have a condition, to go and read on Google and go and see what Google has to say. That's an extremely frightening experience, and to start to in a meaningful way understand and look at, okay, I have this condition, and start to have this compassionate inquiry with yourself of going, okay, so how was my childhood? Was it very stressful? Am I quite stressed? Was I, do I have memory of kind of stomach aches and this and that? And how were my teenage years? And, how would I grade my stress? And, let me look over my last 20 years. What has happened? And then you can start to get an idea slowly of what is my nervous system doing even prior to any diagnosis, because then you can possibly start to see, was there potential nervous system dysregulation prior to your diagnosis? And if you are really honest with yourself and you understand the nature of what we're looking at, you can start to put a picture together. Okay, and sometimes there can be an incident then, so there may have been nothing beforehand, but there'll be an incident that then dysregulates the nervous system, or there's an incident that further dysregulates the nervous system. But the reality is that you need to deal with all of the aspects. And even if there was nothing in the nervous system prior, having a chronic pain pattern will be stressful, will be anxiety provoking, will cause you worry and concern. What if I wake up tomorrow morning and I've got to sit through that board meeting and I can't? What if, and that's where you cannot not be stressed if you have a condition like that. You cannot not. So one almost has to manage all of the moving parts in a meaningful way, depending on how much each almost, is it the diet that's really the biggest problem, or is it, and once all of those are put together, that is when you can actually look at a progression that isn't a progression, but a coming back into balance, a coming back into equilibrium, a regaining your life, being able to do more things, being able to be more active, being able to have a different sexual experience or a relationship, or but it's, I think, more than anything, it's about really understanding how the system works, not the condition necessarily with the label. I don't know if you want to
Absolutely.
comment on that.
Everyone wants a label, and wants everyone wants to know what's wrong. Okay, so I've got vulvodynia. So what does that mean? It means I've got pain in my vulva. Okay, so what are the treatments available? And I want to know that there are 5 or 8 treatments. I want to know which cascade, which one am I starting with? Is this one terribly expensive but works very quickly? And people want answers. They don't want their pain and dysfunction to be an echo of their lack of equilibrium. They they don't they don't want to and many individuals are desperate to change their experience and will do whatever is asked of them and are very compliant. You were just saying it earlier. You were saying you have to looking back into yourself and saying, actually, how stressful has my life been? But that process of interoception, that process of self um, self reflection can be terrifying and very difficult for individuals who are not used to doing it, and individuals who, when they do it, maybe don't like what they see. So we see a lot of individuals who are in abusive relationships, um, and who perhaps lack a degree of power or a locus of control to be able to speak up for themselves or have the resources to do so. So, so I'm certainly not saying negative things about my many patients whom I adore. Um, but a lot of the journey and the path is trying to do your own problem solving of your own particular set of puzzle pieces, or the particular twists that have made your Rubik's Cube turn into what all the scrambled sides it is. And we don't do twist this way and then turn it that way and twist this way for every single jumbled Rubik's Cube. We do not do the same thing. But equally, you could have two very different looking Rubik's Cubes, and perhaps the degree of twisting is going to be similar to get them back to what they were. So this really is patient-centered medicine. I don't have protocols, although almost all patients will have their breathing assessed and corrected. Almost all patients will be given stretchers because they need them. Of course, we've got some patients who are stretchy, bendy people. And in fact, part of the problem is because they stretch too much, and then their muscles have to overwork to compensate for the fact that they have less stability than the rest of us because they of changes in their connective tissue. So you know, even then we've got to be very cautious about saying, hey, you've got pelvic pain, let's just give out stretches. And the last thing we want to do, if we've got 100 patients, it's no good getting 99 of them much better and making one person worse. Because if you took and gave everyone stretches and everyone needed stretches except the one person, and the more you stretch them, the more their pelvic floor muscles are going to be overactive, you shouldn't be giving them stretching exercises. You should be giving them dynamic stability exercises. And that's then not the patient who's wrong. It's not the patient's fault that he or she didn't fit your protocol. Your protocol was wrong. So I'm not a big fan of protocols. There are obviously tick boxes and check boxes, but because of the multi complexity, um, it's very difficult to make sure, and it would be a waste of resources to do everything for everyone. Not everyone needs a cystoscopy or to have their gut microbiome checked. Some patients do need it to exclude disease pathology or to check what's going on. So it is about a patient-centered approach, and we should be looking at managed packages of care. Um, that is a much better model.
And I think, as just commenting on the overwhelm aspect of these types of introspective processes, and look, we all have a scrambled up Rubik's Cube, let's be honest, okay? And it's a matter of at times being able to reach out to the right person to aid you in looking at that component, and looking at how to. I think I've spent more time um, um, trying to unscramble Rubik's cubes than I have anything else, because it is a real unscrambling process, and you may need support in that, and that's okay. And it's a matter of going to the right type of support, and that maybe and it'll be, as Corina mentioned, in chronic conditions, we need a multidisciplinary approach, and we need to have different people, because not every person has every skill set. I'm not going to know enough about surgical interventions, and you need the different team players and whether it is on the emotional side, whether it's in nervous system regulation, whether it's in kind of the pharmaceutical management, the medication that you're taking, or whether or not to have surgery or not to have surgery for something, it almost everything's got to come together. The one thing I just want to say, commenting on surgery, is that when we have chronic pain patterns, generally chronic patterns don't do well with surgery. So just realize that the more irritated your system is, so very often we have a situation where maybe somebody has a prolapse or a hemorrhoid that they want to get rid of because they want to get rid of this pain. And suddenly we remove the one thing and we have a in the system. Okay. So just be mindful of surgical or aggressive intervention when you have a nervous system dysregulation, when you are prone to having a multiple different types of conditions playing up, or a pattern of a systemic inflammation, or a chronic pain. Your body is probably not going to be too happy getting irritated. Okay, it's going to scream at you. That sometimes the prolapse, it's better to just live with the discomfort of the prolapse than to potentially put a whole system into a cascade of pain. So just when it comes to surgery, just be mindful of your invasive treatments when you do have an irritated system.
So one thing on surgery, there's a quite a common pattern we see. You might go in and have surgery, and in fact, your pain does go completely, and it's gone for the first 6 weeks, 3 months. But as that scar tissue begins to form, it actually comes back. And it might even come back a little worse as the scar tissue tightens up. So that's kind of 3 to 6 months post-op. And you think, well, it did work, but it's kind of not working anymore. So I'll go back and have something again. And you go back in, and again, that cutting relieves the tension and the pressure initially. So maybe your pain it usually doesn't completely go, but it decreases quite a lot. And you go, okay, well, that was good. It wasn't as good as the first surgery where it went, but it's less than it was. But again, once that scarring begins to come together and there's even more tightness and restriction, you might find that actually your pain is worse than before you started with the two surgeries. So that was thing number one. I keep getting it where I've got two things in my head and the second one keeps falling out. I don't know if it's age or PTSD, or I don't know what it is.
We'll come back to
Um,
that. There is a question here around movement. What movement do you recommend for pelvic pain? I don't like to walk because of this. So there's always this relationship between, like you say, exercise / movement. And movement's a beautiful word. I actually don't use that, and I'm going to adopt that, because we do understand exercise to be these kind of, and we have very bizarre exercise protocols nowadays that are normal, that are very abnormal in, so movement is it's a beautiful. What do you generally, Corina, what is your suggestion around movement for pelvic pain?
So, well, I'd immediately, when you say that you're not walking, I want to know you're not walking because when you walk, you have pain. Is walking one of the provocative activities? Because if it is, I think that we've got something going on called pelvic girdle pain. And I would then want to manage that very much as a musculoskeletal thing. But if there was pelvic girdle pain, I would also want to see if it is in fact a chronic pelvic girdle pain. And this would have tied in with pregnancies and birth and things. And there's a degree of a musculoskeletal or a movement component, but there are also things about chronic inflammation and stress and sleep dysregulation. Or is it that because you have the pain, the vulvodynia, the endometriosis, whatever the pains are, because of that, you don't like to walk because there is so much pain? Because if that were the case, I would actually encourage you to get moving. And if it was too difficult to walk, we'd put you in warm water with the water up to your approximately the level of your nipples, get some paddles on your hand, and you go and you walk in the heated swimming pool if you are lucky enough to have access to such a wonder. And we would want to get you moving where you were supported by water and the water was holding you up, so you didn't have gravity pulling down on you, but we could still get a degree of movement going on. if of course it is a pelvic girdle pain, where when you walk upstairs or try to sit up or stand up or sit down or whatever the thing is, when you're challenging the pelvis biomechanically, when you're standing on one leg and lifting the other leg to get dressed, or you're walking one leg, um, I then want to see what's going on in and around the pelvis. So again, simply saying I've got pelvic pain and I can't walk, that's not enough information for me. I would take 5 or 10 minutes to try and tease out what that meant for you, and how, is it your pain impacting on the walking? Is it pain during walking? Where is the pain? How does it respond? Maybe if you walk for just a little bit, it's fine, but if you walk for too much, it's worse. And Bettina mentioned prolapse. Is there a degree of something falling out that you're compensating for? Is it that muscles get overactive? Some people say they walk for a little and they feel better, but if they do too much, they land up with a stabbing pain in their buttock. So what we don't want is where if I walk at all, it hurts. So your solution is not to walk, but that's not a solution, because in 1 week you haven't walked, and in 1 month you haven't walked, and in 1 year you haven't walked. And it's not as though if we leave you for 1 year without walking, actually your symptoms are getting better, and suddenly after a year we can say, okay, right, go start walking. If anything, it will be even more difficult, because you will have lost degrees of fit. And in fact, now just walking to the fridge and back, if I haven't walked for the last 6 weeks, simply walking to the fridge and back is terribly difficult. If I walk 5 kilometers every day, suddenly one day I've got to walk 8 kilometers. That's not a big difference from walking 5 if I'd been walking 5Ks every day for months. But if I've hardly walked at all, and you want me to go and you want me to walk 5 kilometers, not a chance. So again, what we're exposed to, we take ownership of. And in order to, I don't feel I can answer the question adequately about I have pelvic pain and it hurts when I walk. I need to know a lot more information. Is this a pelvic girdle pain? Is this limitation in activity because of pain? And one of our goals of treatment there would be to get you up and active, moving, not exercising, and to do it within pain limits. And if it means all we can do is get 100 meters out of you 5 or 6 times a day, and you do that for a week, actually you've walked almost a kilometer each day for a week type thing. So it's trying to increase your resilience, exposing yourself to what you can. Again, with things like stretches, we don't suddenly do a whole lot of stretching. We go into positions that we're maybe not used to going into and that might feel quite uncomfortable, and we just spend time trying to give our pelvis a break from being tight the whole time.
So,
I hope that
Karina,
answers.
what would you, I have, maybe if this person could elaborate a little bit more, we can, extend that discussion. But Karina, what would you, with regards to movement generally, what are your, what are
Top
you
ones.
wanting movement for? So, you know, um, why are we
I
wanting pelvises to move? Why are we wanting people to get moving and finding? And movement is about balance, like you were saying. It's not about kind of just go and flare your pain up now because now we're getting movement. There is an art form and it's not something that we can always go, okay, walk 100 meters or walk 200 meters, because we don't really always know. It's a matter of, it's a trial and error. But why do you want your patients to get moving?
So first of all, movement is medicine. And movement in nature is doubly good medicine. So for those of you who live in urban environments or unsafe environments, are not able to move in nature and can only move in the gym or on your exercise bike at home, you're not doing anything wrong. But really, we are trying to address the whole of you and not just your body moving or exercising. There are many, many benefits to movement, from release of certain chemicals, hormones that impact us. It's a very good way of regulating sympathetic nervous system activity. There are positive impacts because often if we've moved, we're going to be breathing more deeply. So it makes the diaphragm work, which immediately is some parasympathetic activity there. It helps with colonic activity, thereby improving gut health, which feeds back via our vagus into our autonomic nervous system. So it's giving us inputs through the parasympathetics. There a lot of our problems come from being in sustained positions, and it's okay if I'm in a good position, sustain a good position for a while, but if I'm in a bad position, if I'm in a poor position, there's nothing wrong with me doing this for a couple of seconds or even a minute or two. But I don't want to sit here for the next 5 or 6 hours typing on my computer and then going, oh, my back hurts. Well, of course my back hurts. So it's not simply good posture, and we very much moved away from this concept of there is a right posture or a correct posture. There are active and inactive postures, and over here, if I'm inactive, I'm a bit kind of slumped, and if I'm active, I'm sort of sitting up against gravity, and if someone calls my name, I'm already in that active posture. We would want movement because it takes us out of sustained positions, and so few of us spend time in good postures whilst in sustained positions. It helps with flow. Flow is a big thing through the body. It helps with blood flow. It helps with breathing, obviously depending upon the type of movement and activity you're doing. And no, I do not consider more crawling to be activity, just for what it's.
So there's been more information related to that walking question. So the comment is, my pain is balance related and it is pelvic girdle too. So you are just the right person, because Corina did her master's on.
I did pelvic floor muscle function during gait. What's so interesting
So
about the
gait is
pelvic floor muscle,
walking, for those of
gait
you
is
who are unfamiliar. Gait is walking.
what's so funny about the pelvic floor muscles, that they've got so many different functions that they can't always do everything at the same time. So if you've got some degree of compromise in your pelvic floor muscles, and you're given a balance task, if you're told that you have to balance, many of the ladies will leak. And if they're told they mustn't leak, then they actually can't keep their balance. So not in most of us who don't have problems, we can balance and not leak all at the same time. But in people who've got some degree of dysfunction or a lack in their pelvic floor muscles, whether it's because they're too long, lax, and loose, they're all weak because they're long, or whether they're too short and tight. Whatever the reason, if the muscles aren't working properly, they aren't able to work involuntarily, dynamically, to give us these balance requirements. And if they're helping us with balance, they can't help us with continence. And if they're keeping us dry, they're helping us with continence, then they can't do their balance functions. So that's just an interesting aside about why we see this overlap. And I think some of the little old ladies are trying so hard not to leak that they fall over. And others of them, maybe in an effort not to fall over, land up leaking. But you can't do both. I mean, you can if things are fine, but if things are not fine, you might find that you either get to balance or you get to maintain continence. This, coming back to that thing on pelvic girdle pain, if it is persistent and it usually would have started either in pregnancy or around birth, or maybe very shortly thereafter postnatally. But if it has been persistent for years, we really do need to start addressing sleep and stress.
Oh, we seem to have lost Corina there. We'll see if she can jump on again. But, what is really interesting just in this discussion around all of this is that you can actually just see, oh, there you go. Sorry, from my side, you had frozen.
Oh, sorry.
So sorry, Corina, please carry on.
I don't know where you lost me.
We lost you in sleep, and that's where I lost you.
Sleep and stress. They actually address sleep and stress rather than the musculoskeletal aspects. Very important during pregnancy. The musculoskeletal aspects, it is initially all about what's happening in the pelvis and how the muscles are overworking. But if it persists postnatally and becomes chronic, it's actually about the interplay of multiple systems that result in a chronic pain expression.
So here, this is a typical example of this is the same lady with the jaw condition, balance, pelvic girdle, pelvic pain, and that is how our systems kind of interlink. It's like the hip bones connected to the, and we tend to forget the to the, and in these types of more chronic patterns, we do need to look at the interrelation between that. Um,
I love that
Corina,
you just said that, because we're just trying to get our heads around the hip bone's connected to the thigh bone, and the thigh bone's connected to the knee bone, or whatever it is. We're just trying to. You mean it's all connected, and we're still almost talking anatomically. But if I hear a gunshot fire now, and I release adrenaline, my breathing will change, my heart rate will change, I will stop digesting whatever I've got in my stomach. I might piss myself if it sounds like it's too close. There'll be a whole cascade of events. And it's not only that things are connected anatomically, but it's how the immune system and the neuroendocrine, our background messengers, um, then set up these internal environments.
we're going to just do one more question, Corina, if you've got just a few more minutes for us. Our time is up, but I just want to address this last one. Can you give examples of stretch exercises that are good for the pelvis?
So there are a number of them. If I can just do a quick little cheat. Pelvic Pain Foundation from Australia has got a lovely little downloadable form. It's 2 little pages, and it's got 6, 7, 8 exercises. There's one for men, there's one for women. It's your classic happy baby pose. It's child's pose. Some patients like downward dog. I mean, I'm naming yoga poses, but it certainly is not exclusively yoga poses that are available. I would Google Pelvic Pain Foundation Australia and stretches. Or yeah, Pelvic Pain Foundation Australia stretches, and you should be taken to 2 downloadable forms. I'm more than happy to share those with anyone who are interested. I don't know, you're welcome to email me. But there are a variety of stretches. We're looking at things that abduct or separate the hips, um, simply bringing knee up to chest and then knee to the other shoulder, and rotation opening through the pelvis. So again, to just sit here and say, well, you got to do this one and you got to do that one, that might work fine for 90 out of 100 webinar participants, but there will be 10 others in whom actually they shouldn't be doing those particular stretches, because that's not their problem, and they should be doing something much more specific to their presentation. We love deep squats. Deep squats are our best friend, but they're certainly not the only thing available to us. So I think the easiest thing is the Pelvic Pain Foundation's cheat sheet. Those are not the only stretches available, but they are easily available, and it's a good starting place.
Corina, thank you. I just want to ask you, before we close off, where, if anybody wanted to touch base with you, where could they reach you? You are, just maybe explain where you're based, and
I'm I'm in um, I'm at the Kingsbury Hospital in Claremont, and I'm in the Kingsbury Hospital in Claremont, and you can, my website is pelvicfunction.com. My email address is my name, Corina, Corina, at pelvicfunction.co.za. Note the difference. The website is .com, my website is .co.za. And I'm very bad at social media, but I'm trying to get someone to help me. So if you need to find me, I'm around, but it's not my strong point.
I think most physios are not, don't have a strong point in social media. Karina, thank you so much for your time.
Thanks
Thank
for
you
the
for
invite.
your passion. You know, one thing that I always love and have loved and will love about you is your absolute passion and your enthusiasm and your excitement about all you do. Regardless of the discussion, it is just it's just always beautiful for you to share your energy with us, and thank you for all the advice and all the information and for your time. And you know, if anyone wants to get hold of Corina, please you know, touch base with her along, you know, with I think the best would be to drop her an email. um, Yeah. And then, from my side, if you are, and, if you're interested in joining us for any of these discussions going forward and you're not on the mailing list, then please pop onto my website, which is bettinamoser.co.za, and just subscribe to the newsletter, and then you'll get information about what topics are running, and you can join in with pleasure, or you can share them, or I think the main thing is, and especially at this COVID time, a lot of people can't and are frightened to go out. They're frightened to and the stress is just blowing up our nervous systems. So all those kind of um conditions that we spoke of are just staring us in the face, and there are a lot of things that you can do to really help yourselves, that you can do on the side, even outside of seeing one of us. A lot of the times there are time restraints and financial restraints, and many other limitations, but there's lots and lots of stuff. And I think the most important thing is really to just start understanding your condition better, and I hope that this was valuable to you guys. And Corina, thank you again for
I just
everything.
saw in the chat that I got it right. The pelvic girdle pain did start in pregnancy, which is
Uh,
what we would have expected. But again, if it hadn't, it wouldn't have invalidated your experience. It just would have made it more common that it would have started in pregnancy. So nice to know my diagnostic intuition is still on the go. Thank
we
you so
would
much
not
for
have doubted you ever.
thank you. Have a lovely evening all. Thank you so much.
Thank you. Good night.